before I start, I do want to mention the Recovery Research Institute website. I'm sure if you saw Brandon's talk earlier this year, you've probably heard of the recoveryanswers.org. You can sign up for a monthly bulletin, and it's completely free for the public. We synthesize all the up-to-date recovery research and send it to you guys in an easily digestible format. So you're welcome to go online, recoveryanswers.org, and sign up for the bulletin. Looks like this. I highly suggest it. Okay, so today I'm going to start out with a few statistics about opioid use disorder treatment and recovery. Then we'll talk a little bit about findings from the National Recovery Survey, or NRS, a study that was conducted at the Recovery Research Institute led by Dr. John Kelly, my mentor, my postdoctoral mentor, and the director of the RRI. And then we'll talk some more about opioid use disorder and recovery research that's going on outside of the NRS within the Recovery Research Institute. We'll finish with future directions in where we need to go with opioid use disorder research and some of the challenges we face doing this kind of work. Okay, so we all know opioids pose a major public health issue, not only in the US, but around the world. And in the US, over 10 million Americans aged 12 and older have engaged in opioid misuse within the past year. And we know that there are 2 million Americans who meet criteria for opioid use disorder within the past year. Rates of treatment seeking are somewhat low in this population relative to prevalence of the disorder, with only 25% of those who had a past year opioid use disorder actually receiving any type of treatment, and 20% receiving specialty addiction treatment. So 2 million is a large number, but opioid use disorder, we know, isn't the most prevalent substance use disorder. Alcohol is. So while this emphasis on opioids in recent years, well, part of that has to do with the rapid rate at which opioid use disorder prevalence increased over the last decade, and other driving factors here also include overdose. So about 128 people die from opioid overdose deaths per day, and this corresponds to about 47,000 deaths per year. And in this graph here, you can see these rates have increased over the years. But between 2017 and 2018, we did see a decline in overdose deaths that were related to some types of opioids like methadone or heroin. But overdose deaths related to synthetic opioids like fentanyl are still increasing. And there's a huge economic burden. There's a huge economic burden of opioid use disorder. So prescription opioid misuse alone cost the United States $78.5 billion per year on healthcare, lost productivity, treatment, and criminal justice involvement. So we know there's been this increased focus on research to address prevention, treatment, the overdose epidemic, but what about recovery? It's not letting me press next. Do you guys have any suggestions? Oh, there we go. Okay. All right, so recovery. Obtaining prevalence estimates when it comes to recovery is kind of difficult because we don't really have a single cohesive definition of recovery per se. These national estimates here are not opioid use disorder specific, they're for any substance use disorder. Substance-specific measures are somewhat more difficult to find, but these broader estimates suggest that about 5 to 15% of the US adult population is in full remission from substance use disorder, and by full remission, I mean they haven't met criteria for substance use disorder within the past year. And about 50% of those who have a lifetime diagnosis of a substance use disorder achieve remission. The National Survey on Drug Use and Health recently started looking at perceived recovery and suggests that about 75% of adults with a lifetime diagnosis of substance use disorder report being in recovery or identifying as being in recovery. So these numbers speak to remission in those with a formal diagnosis, but what about other definitions of recovery, for example, like resolving a problem with a substance, but not necessarily meeting criteria for the disorder? And these individuals are typically left out of estimates. And this brings us to the National Recovery Survey study. So this is the study that was led by John Kelly at the RRI, and this was designed to estimate national recovery prevalence using a nationally representability-based sample of individuals who self-reported that they once had a problem with alcohol or other drugs, but no longer do. And the purpose of the study was to uncover and discover more about chosen recovery pathways and the things that are associated with them, or predictors. I'm not going to go too much into the methods here, but I will note that we had about 2,002 participants who ultimately, from our pool, who ultimately identified as having resolved a significant alcohol or drug problem. The data was collected in 2016, and the data were weighted to accurately reflect the US population. And if you guys have questions in detail about that, I'm happy to talk about it after the talk. So why does this keep happening? Keep clicking and it doesn't want to, there we go. All right, sorry about that. So the first paper that came out of this study wanted to look at the prevalence of alcohol or other drug problem resolution. So now we're talking a broader estimate of individuals, not just those who have a formal diagnosis. And we ultimately found that about 9.1%, or 22.35 million Americans, have resolved a significant alcohol or other drug problem. And this is what the breakdown by primary substance looks like. So consistent with what we know about substance use disorder prevalence, here we have alcohol as the most prevalent problem resolution category here. And we know the most about alcohol in the context of recovery, probably because it's one of the more prevalent disorders. So, I'm sorry, guys. I don't know why it keeps doing this. All right. So this leads us to our next paper. So we were interested in specifically looking at that opioid cohort within the National Recovery Survey. We wanted to know what was the prevalence of problem resolution for opioids, what pathways did individuals use to achieve that recovery, and what did psychological well-being look like? And in order to assess, so first we found that about 1.8, so the 6% here, corresponds to 1.18 million US adults who have resolved a significant opioid problem. And we wanted to compare that group to the alcohol cohort here because it was the largest cohort and we really know the most about alcohol, just to give us a reference point. In addition, we also looked at 2 recovery durations. So we split the opioid group and the alcohol group into 2 separate groups again. One who was in early recovery, so anyone with less than 1 year of recovery, which we called early recovery, and then mid-recovery, which is 1 to 5 years of recovery, so outside that 1-year window. And when we compared the individuals who had resolved a problem with opioids to the individuals who had resolved a problem with alcohol, we found that the opioid problem resolution group in mid-recovery actually had, there was a higher prevalence of lifetime use of treatment and recovery services relative to the alcohol group, but this wasn't observed in the first year of recovery. So we're not seeing this higher prevalence of utilization of those services across the lifetime. And we thought that this might mean that perhaps individuals who, in order to resolve a problem with opioids and be in recovery longer term, perhaps more service utilization is necessary to achieve longer recovery durations. We also looked at current service use, and and found some interesting outcomes, some kind of expected. So in the mid-recovery cohort specifically, we found that the opioid group reported current pharmacotherapy, so medications for opioid use disorder versus medications for alcohol use disorder, were more prevalent in the opioid group in the mid-recovery duration, but not in the early recovery duration. So perhaps suggesting that continued pharmacotherapy or continued treatment, again, into longer durations of recovery might actually help support those longer recovery durations. We also found that, as expected, the opioid groups in both cohorts were utilizing Narcotics Anonymous more frequently than the alcohol groups, but we didn't see that the alcohol group was more likely to utilize AA, or Alcoholics Anonymous. And this could potentially either point to NA's availability, perhaps it's just the lower prevalence of meetings within a given geographic region or at a given time, or it could be that it could reflect the medication attitudes in these two different settings, with AA being anecdotally somewhat more accepting of pharmacotherapy. And when we looked at psychological well-being, we found something kind of interesting. So in the first year of recovery, those who had resolved a problem with opioids actually had higher self-esteem than those who had resolved a problem with alcohol. But the opposite was found later in recovery, suggesting that self-esteem might be something that we need to address at later recovery durations. And perhaps this has, and this is speculation, of course, but we thought that maybe this has something to do with utilization of more services in the opioid group here, with lower self-esteem in mid-recovery, such that if someone is utilizing more services in order to achieve those longer recovery durations, and they experience lapses, and they experience needing more help and more assistance to achieve the recovery, that could potentially lower self-esteem. However, that needs to be looked at further, but certainly regardless of the reason, it might be something worth focusing on to enhance well-being later on during recovery. The good news is we didn't find any differences between the opioid and alcohol groups in either the early recovery or the mid-recovery cohort in terms of other measures of well-being. So psychiatric diagnoses, psychological distress, happiness, and employment were all pretty much equivalent. So the next paper that we're going to talk about that came out of the NRS looked at comfort with disclosing substance use histories. And overall, the authors found that longer time since problem resolution, so longer recovery durations, were associated with greater comfort in disclosing, and that people were more comfortable disclosing to family and friends, less comfortable disclosing to coworkers, first-time acquaintances, public settings, and media. But we did see that primary substance made a difference, and it was actually the opioid problem resolution cohort that was least comfortable with disclosing their status. And this is important because it ties into stigma and shame, and these can facilitate risk of relapse. So addressing disclosure comfort with either more formal coaching, for example, or other recovery supports might be particularly helpful for opioid use disorder patients. Okay, so now we're going to talk about the next paper that came out of the NRS. This is looking at changes in quality of life as a function of time in recovery. And this isn't opioid specific. This is for all problem resolution groups, regardless of substance type. But in general, improvements occur pretty rapidly in the first 5 years, and then they kind of attenuate, but still continue to improve thereafter. So we're seeing quality of life, happiness, recovery capital, and self-esteem improving. This one here is psychological distress goes down. So all good stuff. But the problem here is that that quality of life, the level of quality of life that is in the general population isn't achieved in these problem resolution populations until about 15 years. So we have measures of quality of life that are population norms, and we're seeing that it takes 15 years for these individuals to achieve the same quality of life as the general population. And 15 years is just far too long. And it's important that we address these issues to help facilitate quality recovery. And this may be due historically to the acute treatment paradigm. So full disclosure, this is not my slide. This is a slide that I absolutely love. This belongs to John Kelly, my postdoctoral mentor. And I really think it gets the point across very well. It's the burning building analogy that he uses, where the building's on fire. We do a pretty good job of putting the fire out. This is akin to us providing acute treatment. We're not as good at preventing it from reigniting. So we're not as good at relapse prevention techniques and mechanisms. However, we're getting there. But this idea of rebuilding materials, giving people the tools that they need in order to further their recovery and continue their recovery, this area is really neglected. So recovery capital being the resources that can help support someone's recovery. Do you have appropriate transportation? Do you have a good social support network? And so forth. And then there's this idea of granting rebuilding permits. So there are all these barriers to recovery. How can we help remove those barriers for others? So keeping this in mind, we do need to remember that, and these are some other findings coming out of the same paper, that yes, we saw that things improve, maybe not as quickly as we'd like, but it's also just not a straight shot. So we know that these things might get worse before they get better as someone starts to recover, and that recovery is not always linear. So for example, improvements in self-esteem and happiness in this problem resolution population appear to be somewhat delayed, and these decline first, and then they start to improve at about 6 to 12 months. So knowing that there might be some fluctuation is important for understanding the recovery process and making sure that others understand that just because some things get worse, that it doesn't mean that you're on the wrong path. But also this points to potential points of vulnerability that we can help to further address, and clinicians can help to further address as well. Okay, so what about opioids? So it turns out that individuals who have resolved an opioid problem or an other drug problem relative to cannabis and alcohol don't achieve equivalent recovery capital levels as those in the alcohol and cannabis groups until about 3 years. This is also problematic because we have now separate populations. So understanding that the opioid cohort, because we're focusing on opioids here, really may be more vulnerable in those first 3 years. And what can we do to help benefit their recovery and ensure that they stick on that path? How can we make it easier? Okay, so I think we have like 2 or 3 more studies left from the NRS, or publications from the NRS, that I'll be covering. So this paper came out, and it looks at recovery identity. So do you identify as being in recovery? In this general population of those who've resolved a problem with alcohol or drugs, about half of them self-identify as being in recovery. And the odds of self-identifying as being in recovery was associated with those who reported greater severity, so greater substance use disorder severity. And I just wanted to note that although these analyses didn't focus on primary substance comparisons, they did compare, see if it changed as a function of primary substance. It looks like the proportion of those who had resolved an opioid problem and identified as being in recovery versus not was comparable to the other groups. But this does need to be assessed further, as it might have implications for the terms we use that are appropriate for different populations. Okay, so how many recovery attempts does it take to successfully resolve an alcohol or drug problem? This is the second to last study we're going to be talking about, and just really quickly, I wanted to review this because I think it's an important thing that we need to look at further. So how many attempts does it take to resolve a significant problem? When we look at it by primary substance, these analyses that were conducted on these figures didn't come out as statistically significant. And it probably has something to do with the variability in these groups. So very wide reports of how many attempts it actually took. And we probably need a larger sample where we're over targeting different populations, like those who've resolved an opioid problem. Because if you look at the median values here, you'll see that it looks like those who resolved an opioid problem may have a slightly higher number of recovery attempts. And I think that this is important to look at because we do hear reports and we do see evidence that recovery from opioid use disorder is particularly difficult, and relapse is relatively common. So how do we help aid individuals to get to that point more quickly? But the good news is, it's not 100. There was no cap at 10 here, but it's not 100 attempts. It's median attempts of about 3, and that's not necessarily bad news. But I do think this is something worth looking into further. All right, so now we're shifting gears a little bit. This is still a study that stemmed from the NRS, but we're going to talk a little bit about medication treatment for opioid use disorder, and medication attitudes. So this paper looks at attitudes about opioid use disorder medications, both agonists like methadone and buprenorphine, also known as Suboxone or Subutex, as well as antagonists like naltrexone or Vivitrol. And in this study, Bergman and colleagues, or in this paper, Bergman and colleagues found that in general, most individuals' attitudes were neutral. That was most prevalent for agonists and antagonists. So you'll see that in this dark bar here. These are neutral attitudes about the medication. And for antagonists, negative attitudes were more prevalent than positive attitudes. And negative attitudes for antagonists were greater than negative attitudes for agonists, which is kind of surprising because we think anecdotally that individuals would have more negative attitudes towards things like methadone and buprenorphine relative to naltrexone, but we're not seeing that here. So this suggests that potentially attitudes about agonists are more positive than we thought. And then they looked at predictors of medication attitudes, and they found that for agonists, if you were in recovery more recently, then you had positive agonist attitudes, or you're more likely to have a positive agonist attitude. Black race and Hispanic ethnicity predicted negative agonist attitudes. And older age, lifetime history of receiving medication, like buprenorphine or methadone, as well as attending a mutual help organization within the past 90 days was associated with positive attitudes, whereas greater spirituality was associated with negative attitudes for antagonists. So to kind of sum up what that study found, agonist attitudes may be more positive than we think. Patient characteristics do appear to influence medication attitudes. And the predictors of negative attitudes might constitute barriers to medication adoption or acceptance. And these are things that we can look into further to help us better understand why individuals might be for or against these medications. So now we're moving away from the NRS, but this is still has to do with medication attitudes. So this is a forthcoming paper that I am currently putting together for submission to for hopefully ultimate publication. And here we looked at medication attitudes for agonists and antagonists in recovery community center attendees. So this is a different cohort now. We're not talking national problem resolution. We're talking recovery community center attendees. The majority of these individuals reported opioids or alcohol as their primary substance. And we found pretty astonishing positive attitudes for both for both agonist and antagonist medications. So 71 to 77% said or had a positive interpretation or positive attitude about the medication. And that's good. This would suggest that recovery community centers might constitute a positive and supportive environment for those who are on opioid use disorder pharmacotherapy. And then we looked at predictors as well, and we found some emerging themes of medication experience. So actually having a history of receiving medication for opioid use disorder like methadone or buprenorphine predicted a more positive attitude. And we also saw this emerging theme of spirituality. So Bergman and colleagues also found spirituality as a predictor. Here we found that spirituality was a predictor of negative attitudes for both agonists and antagonists. And we're also seeing this theme of social aspects of recovery. So in Bergman's paper, it was mutual help organization attendance in the past 90 days predicted positive attitudes for antagonists. Here we're seeing that it's greater social support for recovery, predicting positive antagonist attitudes. And so there are some emerging themes. Okay, so we know medications for opioid use disorder work, and we're trying, all the efforts politically and clinically are to increase the number of patients who are on pharmacotherapy for opioid use disorder to address the epidemic. And we know that there's growing interest in opioid use disorder research in looking at medication and medication attitudes, looking at efficacy in particular is very common for these medications. What about recovery during medication treatment? So I was interested in what we know about the process of pharmacotherapy, because many individuals have to be on these pharmacotherapies for long periods of time. Sometimes it becomes sometimes for their life, their entire life. So I think that it's important to better understand what recovery looks like in that context. And one area that I'm particularly interested in, given my background in behavioral and cognitive neuroscience, is neuropsychology as it relates to this topic. So I wanted to know what studies. There must be studies out there looking at neuropsychology or cognition in the context of recovery and while being on pharmacotherapy. And when I say neuropsychology and cognition, just so you all are on the same page, what I really mean are things like attention, working memory, executive function. So looking at cognitive domains and cognitive functions of the brain. All right, well, I wanted to know what we know about neuropsychology and medication treatment for opioid use disorder in the context of recovery. So I did a systematic review. That was my first step. And it turned out there were only 115 publications that directly or sometimes very indirectly measured cognition. And these studies are primarily cross-sectional studies of methadone, meaning they're not longitudinal. There are only 17 publications that concerned buprenorphine, and there were only 3 prospective buprenorphine studies that resulted in 5 publications. And those publications or studies focused on very different cognitive domains. So sustained attention versus selective attention, for example, which call on different brain systems and would have different implications. And they also looked at different opioid use disorder cohorts. So for example, one of the studies was conducted in Finland, and the participants had a primary substance of buprenorphine misuse, which isn't something you typically hear of as a primary substance in the United States. And the US, you see cohorts that are primarily heroin primarily with heroin use disorder in these studies. So it's very hard to make conclusions about the studies that have been conducted. But among those that have, what are they hinting at? Well, cross-sectional studies that cross-sectional studies suggest that methadone patients show ongoing or additional impairment, cognitive impairment, and less cognitive improvement when compared to opioid naive controls and former opioid use disorder patients who are abstinent, meaning not on medication. They also suggest that buprenorphine patients may be somewhat less impaired than methadone patients, but that's kind of unclear. Prospective studies have shown, at least for methadone patients, that there's probably improvement, at least partial improvement, if not full improvement of cognitive function during pharmacotherapy. And the buprenorphine studies, again, like I mentioned earlier, have mixed designs and outcomes. So what's next? Well, it was pretty clear to me that we need to do studies of buprenorphine that are longitudinal and look at cognition. But let's take a quick step back here. Why do we even care about cognition? Why is it important? So cognitive dysfunction is actually one of the most prevalent categories of secondary disease for opioid use disorder patients. And chronic exposure to opioids in heavy amounts over a long period of time can lead to brain cell death and compromised brain structure. And brain regions with opioid receptors and the other locations of the brain that they connect to are implicated in almost all cognitive abilities. And so if you see this image here on the right, this is a depiction of the rat brain and all of the opioid receptors in the brain and their locations. And these are receptor populations. And you can see they're everywhere. They're located in various different places. And so you can kind of get an idea of why they'd be implicated in so many different things or cognitive functions. So we know that chronic opioid exposure can lead to cognitive dysfunction. And we know that cognitive dysfunction is associated with worse recovery outcomes. This has been demonstrated for a multitude of substances. And cognitive dysfunction can really hinder everyday activities. So did you remember to go to your appointment? Do you remember to take your medication? And so forth. And it also thwarts the benefits of treatment and recovery services. So if you can imagine a patient who has, mild cognitive dysfunction in the context of very early treatment for opioid use disorder, and that individual is sitting in the room with a clinician. The clinician is giving them wonderful information that they can use to benefit their treatment and their recovery. And this is information that they're going to need to utilize in order to further advance their recovery and their treatment. But this requires the individual to attend to that information. So now we have attention, to process that information and store it. So now we're talking memory. Then the individual has to be able to apply that information, to manipulate it and apply it to their situation to benefit them specifically, which is going to require higher level functions like frontal lobe functions like executive function and so forth. And then you have to plan. You have to plan how you're going to implement it. You have to strategize. And so there are a lot of different cognitive functions that go into something as simple as that. And that can really impact treatment and recovery. And so what do we know about cognition and recovery? Well, we know that opioid use disorder patients do show cognitive impairment during early recovery in a really broad range of domains. And we know that there's at least partial improvement of this dysfunction with continued remission or abstinence. But we also know that abstinence isn't for everyone. And some individuals really need pharmacotherapy, sometimes in the long term to be successful. And we know that buprenorphine and methadone work, but they are psychotropic medications, and they do have the potential to hinder cognition. Although I would argue that studies show that we do show that their pharmacotherapies are very good at also getting back homeostasis of the brain, as opposed to cold turkey abstinence. But that's a side note. Ultimately, we know very little about cognitive change longitudinally in the context of someone who's on pharmacotherapy, but is in recovery and has started their treatment and recovery process. Okay, so if we study cognition, what does this mean? Well, if we identify areas of cognitive dysfunction that demand clinical attention, then we can develop cognitive rehabilitation therapies to ultimately enhance medication treatment and promote successful recovery outcomes. So alongside pharmacotherapy to help support it. And this is my current study that I'm conducting. And so we ultimately got funding to conduct a prospective or longitudinal investigation of cognitive changes during that occurred during opioid agonist treatment, meaning methadone or buprenorphine, and how those cognitive changes relate to various outcome measures of recovery, including quality of life and opioid use. We're doing this in an ecologically valid sample of buprenorphine and methadone patients. So this is addressing an important gap in the field. So we're integrating novel outcomes like quality of life. I know that the last one of the prior Bridecare's talks discussed how we focus too much on substance use as an outcome or abstinence, and very little on these other important outcome measures like quality of life. And we're also enhancing external validity and clinical translation because we're studying a realistic patient sample. And many times in this field, individuals will ask you and tell you to control. But if we control, what are we actually looking at? So I think it's very important in the context of this stuff to get an idea of what an actual patient might present with so that we can actually implement these things clinically. Otherwise, we would get a patient that has no comorbidities, no other mental health comorbidities, no other substance use disorder, co-occurring substance use disorders, someone who takes their medication every day and who's not using substances during treatment. I have yet to see that. So if anyone has seen that person, give me a call, but I haven't seen it. And so I think it's extremely important for us to focus on ways that we can enhance our research to then have outcomes that we can translate to the clinical realm. Okay, so in summary, what we've talked about here today. So there are about 22.35 million Americans who have resolved a significant alcohol or drug problem. 1.18 million of them have resolved a significant opioid problem. Individuals who've resolved an opioid problem and are in the first year of their recovery might require additional or more intensive services to achieve longer-term recovery. And those beyond the first year of recovery may need enhanced support to address deficient measures of well-being, like self-esteem. We also saw that those who resolved an opioid problem had the lowest levels of comfort disclosing their substance use disorder history, which would be important to address in the context of stigma. They also have less recovery capital in the first 3 years of recovery. We saw that only half of individuals identify as being in recovery on the national level of those who've resolved a significant problem with alcohol or other drugs, and that identifying as being in recovery is strongly related to severity. And at first glance, this doesn't appear to be substance specific. So the opioid cohort seemed to fit in with the other groups in the context of identity. We also saw that the number of recovery attempts may be somewhat greater for those who are trying to resolve an opioid problem, but we definitely need additional research there, given the variability in those samples. When we looked at medications for opioid use disorder, agonist attitudes were more positive than we might presume. And that predictors of negative attitudes constitute barriers to medication adoption. And we also saw that recovery community centers may be a particularly accepting environment for patients who are on pharmacotherapy. And we also saw the neuropsych stuff that I have in progress, and the study's on hold. Recruitment is on hold right now, but hopefully I'll be able to come back at some point and share some data with you guys on that. But all right, so I've got just a couple more slides left. So I'm gonna go kind of quickly through these future directions. These are broad, but in general, what do we see? What do we need to see? And these are just some of the things that come to my mind. So given that opioid use disorder prevalence is somewhat lower relative to the other substance use disorders, we really need national surveys that oversample opioid use disorder patients with various treatment and recovery pathways. And for example, like comparing those who use pharmacotherapy to those who use residential versus those who self-recovered and so forth. We also need, oh no, it's done it to me again. Okay. We also need longitudinal research. So for example, longitudinal research to confirm the findings, the cross-sectional findings from the National Recovery Survey, which is a pretty big survey in and of itself. And so how do you do longitudinal research that way? Well, I'm not entirely sure I know how to answer that question, but I do know that it is needed. We also need it to study cognitive recovery, and doing longitudinal studies allows us to study dynamic changes throughout the recovery process in an individual, right? Which is really key for us to better understand how these things fluctuate. And it also removes extraneous variability among participants, which gives you a strengthened design. In the context of medications for opioid use disorder, we need to look at patient perceptions about medications, factors influencing low medication treatment seeking. So why are people potentially not keen on using pharmacotherapy? And also studies that look at mechanisms for enhancing medication acceptance and also educating individuals on pharmacotherapy. And we need studies that look at novel therapeutics and resources. So we need novel interventions to enhance distal recovery outcomes as well as proximal ones. So distal, now we're talking continued care. And doing this, to do this, we need to utilize the knowledge of temporal factors and patient characteristics that signal vulnerability and risk. And this can ultimately help lead to individualized, empirically driven treatment and recovery plans. Okay, so additional areas needing attention. I've put essentially everything here, but these are just a couple of the things that are on my mind. So once we're done, I'd love to get a sense of your guys' thoughts. But I'm thinking clearly neuropsychological research and neuroimaging are needed. Studies on stigma experiences, but also stigma in the context of the broader population and how to limit stigma in the general population. Studies that look at facilitating treatment at the system or institutional level. How can we ensure that we remove those barriers for transitions from detox to methadone clinic, for example? special populations, so studies that look at prisoners. We know these are coming out more frequently, but we still need more of them. Studies looking at prisoners, adolescents, pregnant women. We also need studies that look at the promotion of substance use disorder, not studies necessarily, but this is kind of what we need, is to promote substance use disorder and opioid use disorder education, particularly in the context of medical training. So getting physicians or physicians to be comfortable with treating addiction, comfortable with understanding, you know, it's not a scary population, I think is important as well. And then more studies looking at harm reduction. So like Narcan and safe injection sites, for example, and how that affects our prevalence estimates and the well-being of individuals, but also how it affects various communities and so forth. And finally, I thought this was kind of timely, COVID and other infectious diseases. So we really need to identify the best practices for substance use disorder services to better prevent disease transmission. And this is not just in the context of COVID. COVID really got me thinking about this, but you know, common influenza strains can travel far in clinical settings with at-risk populations. It doesn't have to be a COVID strain. We see, you know, recently I saw influenza B very, very prevalent, and you know, many individuals ended up in hospitals because of that. So how do we address disease transmission prevention in the context of, for example, a methadone clinic where somebody is going in to dose every day or maybe every 3 days if they get take homes? I think this is important for us to better understand. I think that we're going to have some more emphasis in this area of research as time goes on. Okay, so I'll briefly discuss some roadblocks in some of this research. So some of the issues that we have are some of the difficulties of conducting this research. Why has it not been done? I mean, one of the examples is for the study that I recently got funding for the neuropsychological study. Everyone told me this really needs to be done, but I'm so glad you're doing it and that it's not me, because it's very difficult to do. This is very difficult research with a difficult population. No one wants to do it, apparently, except for me. But as I started doing the research, and I knew it was going to be difficult, and it is, it's very hard to study these populations. So why? The populations can be transient, especially if you're working with more severe opioid use disorder populations. And this makes longitudinal research difficult. They may not have secure housing. They may not have a cell phone or a good way to contact them. Getting patients interested in research at the initiation of treatment so that you can follow them along through their recovery process can also be difficult. And in order to do that, you really need constant interaction, but also empathy. So retention is always an extensive effort, and there's frequent in-person interaction in order to keep people involved in the research. And it's important to have, like I mentioned, the ability to relate and empathize with the patients, particularly as it pertains to them understanding that we're there to do the research because we care about them, not our pockets. You also get frequent no-shows, so you have to be a vigilant, diligent, flexible person to work with this population. I was not a flexible person, but I have learned to become one. So it's very important to be in these communities when you're conducting this research. Comorbidities are very common. Polysubstance use is very common. You have complex substance use histories, medical histories, and these are all going to influence the research. And that brings us to the next point, which is balancing external versus internal validity. We have a tendency to control, and that limits clinical translation. But if we don't control and we have a small population, then we don't have any internal validity either. And then we can't translate because our research really isn't getting at the question that we're interested in. The recruitment sites. So I have found that it is very difficult to get treatment clinics or pharmacotherapy clinics interested in research. They're often really busy, they're understaffed, and they're sometimes unorganized because they're understaffed. And so getting them interested in the research can be somewhat difficult. There's clinician fear of the research interfering with standard treatment, which I think needs to be addressed. I think that a lot of the individuals who do participate in the research actually benefit from it. And there's the issue of how to ensure the conduct of the research doesn't require any extra effort on the clinic's part. So how can we make sure that we're silent, we're not seen, we're not heard, and we don't get in the way? Because that's what we need to do to be a part of, for it to be a viable recruitment site. We also need to oversample for opioid use disorder recovery in non-treatment settings. When we're outside a treatment setting, and I talk about treatment settings a lot because I'm in the pharmacotherapy realm of the methadone clinic or the buprenorphine clinics. But when we're talking about outside of that realm, opioid use disorder prevalence is relatively low. So to actually get national estimates, or when we're doing research, not even nationally, but outside the treatment realm, how do you get those folks? Also, address the stigma, shame, fear related to disclosure and research participation, making sure that patients are comfortable. How do we make sure that our samples are representative of the broader population? And the research. So the research is a lengthy process for obtaining funding, for applying and obtaining funding. This can take years sometimes. Retrospective reports are always difficult in this research, right? Because we're getting a history of substance use disorders. We want to make sure that we have all that information available so that we can assess whether or not it influenced the outcomes. Also, it's difficult to conduct neuropsychological assessment and get a timely baseline. You really want to get a baseline when somebody is just at the start of their recovery or of their treatment. Otherwise, you're going to miss that window where you get a baseline and it will look like perhaps nothing has changed over time. Opioid use disorder focused research assessments, inventories, and questionnaires are also lacking. We often have to adapt these. So adapting them for use in other substances. So for example, the Penn alcohol craving scale was adapted for opioids in another paper, and so I had to contact that individual to ask them if they had that adapted version and if I could get a hold of it. But for a lot of the other stuff that other assessments that I've done, I've had to make my own forms, and this can be difficult for conducting multiple studies and comparing them across. I think one of the biggest difficulties of the research for me is a desire to help these individuals, help them with their recovery, help them with their treatment, help them get a pair of shoes if they need it, but knowing that I can't interfere, knowing that that I'm meant to do the research. So balancing that desire to help with knowing where I need to put that line, but also maintaining empathy and understanding for the population. Which can be difficult because you go home thinking about them, but you can't necessarily go out of your way for them. And then needing outcomes beyond abstinence and percent days use. So we already talked about that a little bit. So with that, I'll give you our Recovery Research Institute family tree. So this is acknowledging John Kelly, the founder and director of the RRI. And then we have our other folks here, many of whom were mentioned or who are authors on the publications that we just reviewed. So with that, I'll leave you guys with our reminder to sign up for the bulletin. I don't get paid to advertise either. So I just think it's a great resource.
Thank you so much, Lauren. Whoa. About that. Me and my partner were watching next to each other.
Awesome.
Yeah. So if anyone has any questions, if you just want to either raise your hand or write it right in the chat, we'll take those now. So one question that I had is, how do you think we could get the spiritual leaders, or, you know, just change these spiritual people's attitudes towards different types of recovery, and, you know, how we may be able to appeal?
Right. I think that's really important. So I'm not entirely sure. So when I thought about the spirituality thing, part of thinking through that, because we did look at attitudes to medications for emotional problems or psychological problems that are not substance use disorder. Those were, spirituality, I think, came out as a predictor of that too. And so we were wondering if maybe spirituality was actually getting at more so like a holistic lifestyle rather than a spiritual in a godly sense. So we definitely need to investigate that further, because I imagine that individuals who want to take more of a holistic approach to their spirituality, don't want to take medications, or are just in general prone to not wanting to err on the side, or wanting to err on the side of not taking medication. But when it comes to getting people actually interested in pharmacotherapy, part of the reason that I was interested in bringing in cognition and neuropsychology is because there are a lot of people in the clinics, at least that I've walked into, and the people that I've worked with, who say you're going to be disabled the rest of your life because you're on pharmacotherapy. You're going to, you know, lose all of your bone mass. You're going to have cognitive impairment, and that's completely not true. I know people who have been maintained on these medications for long periods of time and are doing very successful with them. And I think people have misinformation. We also don't know if it's going to affect cognition. So if we can show that you can actually still improve your cognition, you can actually improve all of these other things in your life, and you're not going to have these negative long-term consequences, then what are the concerns? I think that we need to do a better job of actually showing that there are benefits to the medication, and to debunking the myths about medication, the myths about those pharmacotherapies, and then getting an idea of the perspective of the individual who has those negative thoughts and why that might be. Is it just that they personally don't prefer to do that? Is their severity less so, and maybe they just don't see a need for it? Or is it more about their feelings towards other people who are on the medications? I think it's important to distinguish between thoughts about self and medication versus other taking medication. Yeah, I think that we need to educate more, but we also need more information to be able to provide that education. And it's really astounding. I started out actually in the alcohol field, and it's astounding to me how much we know in the alcohol literature. I used to write papers, and I'd be like, there are 100,000 papers on this topic. You know, what's the point of us doing it again? But I get it. We need to look at it again, and we need to assess the minute points in it. So we're looking at minutia when it comes to treatment and alcohol. When it comes to recovery and opioids, it's you know, it's a field that's almost non-existent.
Thank you so much. Thank you.
Yeah.
We have another question from Ian. Given the nature of life events for long-term users, have you considered screening for TBIs as a contributor to cognitive dysfunction? And have you found that any of your subjects have ever been screened for TBIs in treatment?
Oh, it's a good question. So as part of our neuropsych research and any cognitive research, I think it's typical for us to ask about traumatic head injuries, traumatic impairment, but also just overall health, like HIV and AIDS, untreated hepatitis C, because these things can all affect cognition. So there are a couple of things that in my research, because it's neuropsych research, that we do exclude for. So I do exclude for severe traumatic brain injury. So I would say that the majority of the individuals that I've come across thus far don't report traumatic brain injury, but it depends on how you define it. We know that we have, overdose and lack of oxygen can lead to some traumatic brain injury in that sense. So yes, we do assess it. When it's smaller studies like this, we don't include individuals who have traumatic brain injury. If, however, we were doing a study where we took this one step further, we identified what the domains were that needed improvement in different populations. Like there could be differences between methadone and buprenorphine patients, and we need to target different cognitive functions to amp those up. But ultimately, if we were to do that, then we could create a neuropsychological test battery and then incorporate those individuals as well who have traumatic brain injury as well, and see if they benefit too. I feel like there was a second part to that question. Was it just evaluating traumatic brain injury and whether or not it should be, how do we help those individuals?
Have you learned if any of your subjects ever were assessed for TBIs while in treatment?
That's right. I actually don't know that. That's why I said that's a great question. I don't know. I'll have to ask. I wouldn't want to say one way or the other. I imagine that during a clinical intake, they're asked about their history and assessed. They're asked about it. I don't think anyone does a neuropsych assessment to assess for traumatic brain injury, though. It's a really good point.
Thank you.
Yeah, that is interesting. I definitely look forward to hearing about whether or not. So we do have a question from Lori. They're wondering, one of what I consider is an important thought is there any interest in studying the family as recovery capital? Families are really left out of everything, and a last thought, even if even thought about at all.
Yep. I think I think that recovery capital is assessed on a broader spectrum of what are all the things you have. And usually we use scales where we can then assess different categories of where that capital lies. I also agree that family is a huge component. The reason that I got into this research is because my mom suffered from opioid use disorder my whole life. And as a young adult, it was my job to lead that responsibility of how do I help? And yet I was too young to understand, but if I wasn't there and my sister wasn't there, it could have potentially, gone downhill very quickly. There wouldn't be anyone there to assess whether or not, if there was an overdose, who's going to call an ambulance, who's going to get you to the hospital. Family is huge. Especially when it comes to adolescence too, assessing adolescent opioid use disorder. I think that there is a lot of emphasis on family in clinical treatment with adolescents. But I also think that we could do a better job of evaluating not only family, but close social circles. And it can be difficult to fully understand what someone's social circle fully entails. But I know that there is some research ongoing about alcohol use disorder, various social circles, not only proximal, but very distal social circles and how that might influence recovery outcomes. But I think there's a lot when it comes to relapse, not only relapse early on, but relapse much later on in recovery. what triggers it. And it's probably not just one thing. It's a lot of stuff. I would imagine that accumulates over time, but I'm not exactly sure, and I don't think we have the answer to that yet. That's a good question.
Thank you. So Diego asks, did you have sufficient numbers to study whether Black Hispanic recipients of MAT had the same negative attitudes as Black Hispanic survey respondents in general?
Oh, okay, yes. So Black Hispanic survey respondents in general versus those that were on medication. Okay, I see a nod. Versus those that were on medication. So I don't think that we looked at that. I'm not entirely sure. That paper, I don't think I was an author on that paper per se, but I can probably look at it. If you want to send me an email, I can take a look and send you the paper.
All right, we'll make sure Diego reaches back out.
Awesome.
So let's see here. Sari says, in terms of neuropsychology, I'm wondering if there is any research that is looking at the shape of the brain at the receptor level and how that might change over the course of MAT. In short, I'm wondering if there is any indication on whether mu receptor ever downregulates while in agonist or antagonist treatments.
Right. So the idea being that when you have medication treatment, so you have mu receptor, I believe you get mu receptor downregulation as a result of chronic opioid use. Then when you bring pharmacotherapy on, you're not stimulating the receptor so much that you don't have that typical, for example, heroin high when you introduce pharmacotherapy. Pharmacotherapy helps to then regulate and stimulate the receptor at a pace at which it's not so overwhelmed, and then it can then upregulate some mu receptors thereafter. So the brain does, the receptors do change during pharmacotherapy. I don't know that they have looked at, I know there are new studies or new methods of imaging neurotransmitters in the human brain. It's a little different though. I know that a lot of these studies are based on animal models. So give an animal heroin via injection over a certain number of days, then administer, let's say like pharmacotherapy, what happens to the brain and the receptors. You do get, I think you do get some ongoing downregulation of mu receptors with continued pharmacotherapy use, but it would look more, in my opinion, it would probably look more like a continued improvement, right? Because you have so much downregulation to begin with that you then get back to homeostasis, whether the medication is on board or not. And then there's the idea of kappa receptors. So there are other types of opioid receptors like kappa opioid receptors, which are only targeted by buprenorphine and not methadone. And kappa receptors, we're not entirely sure what their purpose or function is, but we think it might have something to do with anxiolytic effects or anti-anxiety effects. And I have read some studies on kappa receptor regulation and how that might be affected over time in buprenorphine patients, but I don't know that we know enough just yet in humans.
Thank you so much.
Sorry.
Not gonna lie, I was a little lost on that one. But.
Sorry. That's an interesting question. I mean, if whoever asked that, if you want to talk more about it, I'd be interested to see what you've seen out there, what your background is.
I have a question from John, who I accidentally skipped. I'm so sorry. Have you thought about differentiating stigma from medical distribution in attitudes towards MOUD? I'm not suggesting that there is no anti-mod stigma. There is, but much of what I hear on the ground is about distrust of doctors and drug companies, especially doing training in communities of color.
Right. Remind me what the first part of that question was again.
Sorry. So they're asking, have you thought about differentiating stigma from medical distrust?
Right.
Yeah.
Right. Okay. So yes, I think that there are multiple layers to it. Because stigma is one factor, and I hear in my communities of those who are in the methadone clinics and in the buprenorphine clinics, you know, oh, it's all these guys who are coming into the clinic and taking the methadone, but then they go out and they take other things on top of it to feel a certain way, and they're not actually in the treatment or in the therapy, and everyone looks at us like we're the person who shuffles their feet down the road because they're actually on so many other substances, and yet they're a methadone patient. This is like the negative perception of what the public has about what a methadone patient is. I know this is not what a methadone patient typically is, but many others don't. I think that some of that stigma from the public has to do with negative perceptions, probably historically. When it comes to patients and getting patients interested in medication, I definitely agree that there's a dissociation between stigma against medication, distrust of medical communities, and also, you know, that goes back to distrust of research communities too. Like, how can I trust this person? And if I'm not there in the room talking to them and giving them a sense of like, this is my background, this is my story, I've dedicated my life to wanting to help people with opioid use disorder, then they can't, if I don't do that, they're not going to give me the time of day. They don't trust me. I'm just another person who's there to make things difficult for them. I think that there is a lot of distrust in the medical community. I think that we need to assess that separately from stigma. I 100% agree, because stigma is slightly different than preconceived notions about medications, which is slightly different than distrust in different areas. Also, seeing someone on the medication, have you had an experience of seeing someone on the medication? Do you know someone who's been treated with this medication? Did their experience make you feel more positive or negative about medication treatment? I think those are important to assess as well. I don't think we know enough yet about why it is that so few people are actually receiving these treatments when we know they work. But we also don't want to push medications on people either. It's not like we're trying to, I hear a lot, they're trying to put me on medication because they want to zombify me, and it's society wants to zombify people who have opioid use disorder. And it's like, I get it from the big cat perspective. Like, when you're thinking like that, yeah, it could seem like it's really negative, but us in the clinical and research realm, it's like, no, we care about you. We want you to live. We know this will work for you. We think it's going to be a good thing for you. How can we get you to at least consider it? Yeah, I think it's a really good point. Medical distrust. I guess because I'm in those clinics so much that they're already in the medical setting, that it's more annoyance than distrust. But yeah, it's a very good point.
Thank you. We have another one from Lori here. In any of the studies that you've looked at, is there any difference in results depending on the method of administration for the opioids?
Yeah, so in the studies that we presented today, I don't think we looked at administration because the samples were too small to then break them down into individual groups, because opioid use disorder is less prevalent. But we do know that someone who is injecting IV is going to be on the more severe spectrum than somebody who's taking prescription opioids orally or misusing prescription opioids orally. And we also know that there is a small percentage of individuals who are also using opioids via insufflation or snorting. And there are differences there. So the severity is a big factor in determining a lot of these outcomes, I would imagine. Yeah. Another thing that I think is important to kind of consider is the change in heroin over time and how so many individuals know that their heroin isn't heroin anymore. They know it's fentanyl. And some individuals will actually report fentanyl as a preferred substance. So there's this confusion over fentanyl, heroin, how someone's using it, that I think makes opioid use disorder research a little difficult as well. Also, looking at the amount someone uses is going to depend on the amount of heroin versus fentanyl and the ratio and proportion. It's kind of like studying cannabis. No one really knows how to measure the amount, just because it's not consistent. So it's like, unless it's sold by the government, in which case you know what's in it and who's using those particular substances, what's the strain. For opioids, it's very difficult. Yeah.
Great argument for safe consumption sites.
Yeah, and I think that that's a tricky topic. And it's because there are a lot of people in the public who might think that having those safe consumption sites and having those needle exchange sites are going to bring, all these people into their communities, and it's going to cause chaos and there might be higher crime rates. And I think studies have suggested that just time and time again, that's really not the case. It's really the opposite. And I think it's difficult to get people on board with really embracing addressing the opioid use disorder by providing people with resources. It's bizarre, but it's trying to prove to individuals that it's like, okay, well, if you want us to do something about it, you have to help. You can't take everyone with opioid use disorder and put them in their own state. Everyone has to be a part of this and understand. I think a lot of that is educating the public on what opioid use disorder is, give them the face of recovery. It looks like all of us, we're all just people. And I think that some people have very strong opinions and misconceptions, and I think educating people over time, even if they're reluctant to be educated, might help.
Thank you so much. I'm one to educate the reluctant, so.
You and me both.
Yeah, I can feel that one.
Yeah.
Ian has a question. He says, as a scientist and researcher, how do you define remission? Oh, sorry about that. How do you define remission from OUD? And does your field generally conflate remission and recovery or not?
So remission is defined as not showing. So there's full remission, which is not meeting criteria for a substance use disorder, meaning those DSM-5 criteria that are needed in order to give a diagnosis. So you don't meet enough of those criteria. I think in order to meet a mild opioid use disorder, you need at least 2 criteria, is it? But if you don't meet those criteria over the past year, then you're in full remission. And then you have partial remission, which is I think it's 3 months, up to 3 months of continuous or of not meeting those criteria. So remission is a pretty standard definition. it's DSM-5 criteria. Do they meet it? Do they not? What's the time frame that they meet it? And I think that as a researcher, that's the easiest one for me to use because it's a formal definition of recovery. So it's the most clean definition that we have. It's easy to look at, but then we have recovery in other aspects, and that's very seldom looked at. The National Recovery Survey was like one of a kind. It really looked at problem resolution as opposed to remission. I don't think that enough of our these large scale national studies, like the National Survey on Drug Use and Health, for example, they're starting to get the sense that we want to know about recovery and we want to know about the prevalence. We want to know how many people. And before now, they really didn't look at that. That one figure that I showed you guys on recovery identity in substance use disorders, I think that just came out like about a year and a half ago. And it took from what I understand, it took a lot of convincing and pushback to get that measure in. So yeah, I don't know that the numbers are probably lower than they actually are. So the numbers that come out of these national surveys, like the National Survey on Drug Use and Health and so forth, these are good estimates. They may be a little bit higher than the numbers we actually see, because individuals may be, we rely on people to tell us that they've had an issue or problem with a substance, and people might be reluctant to disclose that information or might interpret problematic use differently than we would scientifically or more strategically, methods wise. So I think we need more studies on recovery, and I know that there's a big push to define recovery, but then that gets into the issues of who owns the definition of recovery. Then recovery, in a sense, should be an individual's definition of recovery. It should belong to the individual. I get the reason for making a definition of recovery in the science field, and that's so that we can all be consistent in our research, and we can make sure that we're all looking at an outcome measure, and we can say when we're talking about recovery, we're not misleading people. It's just one definition, or we may have different definitions of recovery and we call them different things, but then we can at least look at it systematically as a field, as a research field. But when it comes to clinical landmarks for determining whether patients have actually achieved recovery, that's where it gets a little more difficult, I think. And I know that recovery means different things for different people. And I know that if I were to ever challenge my mom's idea of what her recovery is, she wouldn't have it. And I don't think she should have to. I think that everyone should be able to have their own understanding and identity of recovery, but also we need to think of better ways as a community, both in the clinical world and in the research world, to make it more systematic, so that we can extrapolate across studies. Does that answer your question?
Thanks. I appreciate your thoughts about recovery for sure. I've seen some writing that suggested that remission from opioid use disorder is typically more extended than from the other substance use disorders, which is kind of why I asked specifically about your definition of remission, or your working definition of remission, if it was beyond the standard SUD, Surgeon General's definition, or not.
Yeah, no, when talking about remission, it's just simply remission as defined the way the Surgeon General probably does as well.
Okay, thanks.
Yeah, sure.
Thanks so much. We do have another question here from Diego. Regarding the 15-year QOL gap between recoveries and the general population, could you control for traumatic childhood events or other relevant QOL factors? 15 years is a big gap, but maybe it just takes time to repair generations of trauma, which present sometimes in substance use disorder.
Right, exactly. And there's probably small cohorts within that larger cohort who have childhood trauma, or childhood or adolescent sexual abuse, for example. Those cohorts are probably going to look different in terms of their quality of life, their substance use trajectories. I almost put in the talk that we kind of need to assess opioid use disorder typologies as it pertains to the disorder and the recovery. We've done it with alcohol. I think maybe we might benefit from doing this with opioid use disorder. But yeah, I think we haven't broken them down because I've also realized it's difficult to assess trauma that happens during adolescence, not necessarily because individuals don't feel comfortable talking about it, but because it's all from their perception. So they may not actually perceive it as a trauma because they haven't worked through that trauma yet, despite the something occurring that was probably impacted their life. And I do think that quality of life could vary with that. It might also vary with people who actually are utilizing certain services that are allowing them to work through different problems in their life, or if they're attending like a recovery community center that offers them a linkage to employment and housing. And then all of a sudden you have these recovery resources that you need to then build recovery capital and further recovery. I think it's a really good point. And I've kind of tackled with how to assess traumas, because we know they're early traumas, but we know that in the life of an individual who suffers from a substance use disorder, like, if you've lived it firsthand or secondhand, there's not just, if there are traumas, it can range from 1 to 100,000 throughout the course of a person's substance use disorder before they actually, achieve recovery. How do we capture all of those moments, and how do we ensure that none of those carries over into recovery and affects recovery such that, you get relapse, or someone doesn't facilitate their recovery as quickly as another? I think that's a really, really good point. And I don't know that we know how to assess all of them, right? We get at it a little bit. There are some questionnaires that get at childhood traumas or past traumas, which is kind of akin to looking at like PTSD related disorders, but doesn't actually get at the nitty gritty. And I think we might actually need like, conducting interviews and doing research that's more qualitative than quantitative to really get at what's going on there. It's a really good question.
Thank you. I'm just going to throw in more qualitative data. Let's do that. Let's see. I just got something in from Ian here. You may have covered this and I missed it. Do you see a difference in neurological effects with women versus men?
That's a really good question. Yes. So typically you do see some differences in terms of, I don't know this literature as well, and I actually don't know that it's as up to date as it needs to be. I know that with substances in general, you get a dissociation between men and women, cognitive areas that are affected. But also, substance use histories have a lot to do with that. Metabolism, the way that the drug is processed. I imagine that we might see some gender differences. I'm not quite there yet in my research in terms of pharmacotherapy. And I don't know that literature off the top of my head, but if you're interested, also, again, welcome to email me, and I can see if I can find some resources for you. I'm sure there's got to be a review out there somewhere on sex differences as well as gender differences. So differences in gender identity and sex and how that relates to cognition. And we know that the brain develops somewhat differently in men and women. So we would assume that those differences might carry into the context of cognitive dysfunction as well. It's hard to get at though. You gotta control for, that's where all the control gets implemented. The chronicity of the substance use disorder, the frequency and amount they were using, how far along are they, did they, in their treatment or in their recovery, and so forth.
Yeah, there's so many variables, and of course the addiction and the recovery trajectories are so significantly different for women than men. So I'm just wondering if that's reflected at the based neurological level.
Yeah, I imagine there are studies on that. I don't know them off the top of my head, but I do know in the, not in the context of cognition, but more so in the context of disorder and transition to treatment, that women tend to telescope or to transition from first use to regular use to problem use to treatment seeking more quickly than men. And so there's this different transition in the history that probably also plays a role in the difference of neurological consequences as a result of chronic opioid use.
Yep, you know your stuff.
Good question though. Yeah, if you're interested, please feel free to email me, and I'm actually curious now. Once we're done here, I'm gonna go try to find a review on gender differences.
Oh, good. Thanks.
So thank you.
Yeah, I was wondering something similar as well, but I was wondering if you had taken anyone's sexuality into consideration at all, but it sounds like it's a no.
Well, I mean, not that we haven't in general. I think in terms of cognition, we're less interested in terms of like executive function. I'm not talking like emotional and social cognition. We definitely know there are differences there gender-wise, but with neuropsychology and like neuroimaging, for example, people like to focus on the sex because it's the biological sex of the individual that therefore results in brain development and differences in metabolism. But you have other cognitive processes that are going to be mediating that surrounding gender. And I think that gender identity is a factor that people are paying more attention to now. And it was a measure that we included in the NRS study. I believe I am also collecting that in my study currently, although it's not a focus of it. It is part of the demographics. I have my best friend's actually very interested in that area of research. So I hear a lot from her about gender identity, different gender roles, and how that might impact someone's experiences of trauma, experiences of stigma. I have a feeling it plays a role, at least if not a little role, maybe a medium-sized or a big role in how people are perceiving different things. And it can also probably perpetuate even more stigma, right? So if somebody is worried about the stigma of opioid use disorder and they don't identify as a heteronormative individual, how is that then affecting their experiences of stigma, not only on the level of opioid use disorder and recovery, but also their identity and their gender and attacks on that potentially in the past. I think it all ties together. Yeah, that's a good point.
Thank you. Yeah, no, I definitely feel it's intersectional. I also had another question. So you were talking about one of the studies and how there was this many people who identified as having experienced problem substance use before, and then this many of them consider themselves in recovery. So do you, like, when you're communicating with these people, do they seem to not like the idea of considering themselves in recovery, or does it seem like they don't even realize that they could? Is it because these are mostly, non-abstinent people in recovery? Like, what does that look like really?
Yeah, so when we go in and look at the specific reasons, I've seen various ones I was trying to get a sense of why that might be. When looking at the anecdotal reasons, that they had free form text box that they could type into to give a reason for that. Some were, I don't think that I think I'm still working towards recovery, that I'm not fully there yet. Even though they resolved their problem, they didn't feel like, some people thought that they were thinking that they didn't feel recovered yet. Other people felt recovered and thought recovery was more of a process that you're in when you're trying to recover, versus the problem was so long ago that I don't really consider myself in recovery. I imagine a lot of that has to do with whether or not someone's actually, has a social circle that's in recovery as well. Like, do you attend NA or AA? If you do, I imagine that you might be more likely to identify as being in recovery. I'm not sure if that paper looked at that or not, but I imagine it would play some role. And yeah, in terms of recovery identity, you asked something else, I think. I'm trying to remember what it was. I got lost. Oh, you're on mute still.
Sorry. I think you pretty much answered the whole thing.
Okay.
Yeah, just pretty much what they were responding with and how y'all approach that.
Yeah. Other reasons. I think some of the other reasons were, do you identify as being in recovery? Yeah, I think it was primarily just, those identifying as recovery being a process, and they've been there, done that, and they feel recovered. Others feeling like they didn't yet deserve the label, because they just weren't quite there yet. Yeah, it's a good question.
Yeah, thank you so much.
Yeah.
So we have another here. Given that so many more people consume/try cannabis than cocaine, the relative equivalence in SUDs for cannabis and cocaine tells you what? Cannabis is less addictive, ? I guess that's asking whether the research would tell you whether cannabis is less addictive because people consume and try it more.
I mean, so addiction has two processes, right? There's two components to it. I mean, there's the psychological aspect, and then the physiological aspect. So physiological dependence and psychological dependence. I think that colloquially we tend to think of cannabis as something that people can't become addicted to. But we know that studies have shown that this isn't true. And I don't know if I want to speak to the potential for someone to get addicted to cannabis over cocaine. I don't know that the prevalence estimates also tell us that. Do we know that more people are using it? Do we actually have a prevalence estimate of this is how many people have used it in their lifetime? This is how many people have developed a use disorder for that specific substance. We have past year misuse, lifetime misuse, right, in the national surveys. So we can probably compare and contrast. I don't have that data in front of me, so I don't know exactly what those look like, but I'm a little reluctant to say anything about the predisposition for developing a substance use disorder with cannabis is because cannabis is less addictive. I don't know that that's the case. I think it depends on looking at how these things are affecting the brain, and also the way that we define the disorder, because you do have a psychological component and a physiological component, and both of those are just as important. Someone might feel like they can't cope without taking a hit of marijuana before bed, or they can't cope if they start to have an anxiety attack, but they might not be aware of themselves developing this psychological dependence, needing it in order to feel okay. And so I don't know that it speaks to that per se, but interesting question.
Very well danced answer.
Oh.
No, I do think that was a very good answer.
Thank you. I appreciate it.
Yeah. I think you've answered my questions. If anybody else has any last questions, please put them in the chat.
Speak now or forever hold your peace.
Speak now or email me later.
Yeah, exactly. Pretty much.
Yeah, right.
And I could give you guys my email. I don't know if I can access see if I can access the chat and put
You
it
should
in.
be able to get into the chat.
Put it in there for you guys. It might have been in the flyer, but just in case.
Sure.
No, this is Gail. We didn't put it in the flyer.
Oh, okay, perfect then. To everyone. All right, it's in the chat for anyone who has follow-up questions.
Lauren, could you, again, this is Gail. Could you provide me with the slides? And I'm going to try and get this up on the website for everybody.
Yeah, sure.
That'd be great.
Absolutely.
Thank you.
Perfect. So the slides will be available to y'all. I just want to thank you, Dr. Hoffman, for joining us and giving us this awesome presentation and doing our Q&A.
Yeah, thanks to you guys. This is awesome.
No, it's really great. I'm glad you could come out, right?
Yeah, exactly. Hey, I'll be there one day. I still need to tour all those regions, and John promised me.
Oh, there we go.
Yeah.
All right, perfect. And yeah, no, I just want to thank you again. Thanks to Cobre and Brown to helping us out at Ride Cares.